tell me what to do. I'll
Yep.
zoom in when I need to.
Hi, my name is Meister Gwelly. I'm a hospital medicine provider here at the VA, and I spend half of my time in the simulation lab. The point of this video is to really show how to do a central line. So we have our mannequin here, who's essentially the standardized patient, or the patient that we're going to be putting the line in. You're going to grab ICU central line bundle. Here at the VA, everything that you need is included in that bundle. I believe at University of Cincinnati, the bundle is also 100% complete. So you should just grab one of those bundles. But if you end up in a position where you don't have the bundle access, you want to grab certain things. So this is a central line kit. You want to grab an ultrasound probe cover, a central line dressing kit for later, a bio patch, 3 caps, though this I believe includes caps. You want to grab a couple saline syringes that are going to be, if they're in the plastic wrap, they're non-sterile on the outside and sterile on the inside. That matters, and we'll talk about that as we go through the procedure. Full body gown. This isn't a full body gown, but you want for your procedures to have a full body gown, your gloves, your gown, a couple extra chlorhexidine preps, and perhaps a lidocaine or 2 depending on whether your kit has it or not. You can see I'm already in a mask, a face shield, and a bouffant. I'm going to be in sterile gloves and a sterile gown. I will wash my hands now. I will talk to the patient about contraindications, indications, alternatives to the central line. I will say, he will agree in theory. He'll say, yeah, it's okay for us to do the central line. I'll do a timeout, which is essentially, hey, this is patient mannequin 1. I identify 2 sources of identification, whether it be the bracelet and a name identification. I will make sure that the patient is then, I'll say stop. We're going to do timeout. We're putting in a central line into this mannequin, into the right IJ, for the purposes of establishing care in critical access. I'll place a timeout sign on the door, and we'll be ready to begin the procedure. So the first thing you want to do is make sure that the patient is on a cardiac monitor for parts of the procedure that happen in the future. You want to make sure that the patient is in as much Trendelenburg as they possibly can tolerate, and you want the patient to be at a comfortable level for you. Believe it or not, sometimes it's at the waist or higher. So this is as high as our bed can go, but even this might not be high enough. You want to make sure that the patient is positioned in this position where ideally, if you're looking at the right side, you'd end up having the patient facing left. We've already identified a good vein before the video started in our mannequin. You'll want to do that before you begin, making sure that you're not missing anything, specifically looking for good access, what the vein artery location looks like, and we'll talk about that as we go through the process, as well as making sure that you don't have any kind of thrombi in that vein. So this is in our way right now. Ignore this. You'd actually put this away, but I'm leaving this because this is our audio for the video. So this is something you'd want to kind of get out. You want all this stuff to be out of your way. I am going to teach a hybrid of 1 and 2 person line assistant placement. So the purpose is that I am teaching how to place a line with an assistant. There are ways to do without an assistant, but I am not going to be able to teach that. That's a little bit outside of the scope of what I'm hoping to teach you. So I've grabbed all these things, and I'm going to get my kit set up. So the first thing I want to do is I want to open up the kit, making sure that I'm not breaching or introducing any breaches into the sterile field. So I'm opening it up here. There is a chlorhexidine here. And what I will do is I will go ahead and just do a preliminary wipe. So this particular chlorhexidine wipe session is not necessarily for sterility, but this is the first sterile process. So I'll scrub. And really, when you are sterilizing with chlorhexidine, you want to make sure that you sterilize for 30 seconds in a mechanical way in the area that you're going to go, and then you create a large swath of an area after that. I'm now going to open up my kit. And if I was doing this for regular purposes, I'd actually have the kit a little closer to the bed and a little bit, like if I was actually going to place a real line, a little bit more into the space. Because what I really want to do is I want to create a confluent sterile field from the patient, from the end of the patient, all the way to my workspace. I'm moving this a little bit out of the way so that it is better from a theatrical standpoint and better from a visual educational standpoint. So hopefully you can see what I'm doing. So I'm opening the kit here, making sure to not touch the inside of the kit. And I'm actually going to spin this way. And now that I've got a sterile kit open and ready to go, I am going to go ahead and drop a couple things on here. I'm gonna drop an extra chlorhexidine prep or two. All the things that we said, I would ask for an assistant to spray saline into the field, but because it looks like we have some space to spray saline, I'm gonna go ahead and spray the saline now. I will leave an extra 10 cc syringe just in case I need it available over here. So I went ahead and I sprayed the saline. I'm gonna go ahead and open the probe, the probe cover for the ultrasound probe. That can be dropped on the sterile field as well. A dressing kit can go off to the side. This is a bio patch. I'm gonna go ahead and drop the bio patch onto the field itself. And then this is a full body drape. So this would normally be in a sterile covering, and I would actually open the sterile body drape onto the field the same way that I dropped all this other stuff. This one, as you can see, isn't in packaging. So just pretend like I'm dropping this in a sterile way onto the field. So now that I've got everything ready to go, I'll drop an extra chlorhexidine prep here. I like to drop 2 on the field, and I'll explain why that second one exists as we go through the procedure. I have my sterile gown here and my sterile gloves here. So the first thing I want to do, as with any procedure that requires sterility from both a gown and a glove perspective, is I'm going to go ahead and get my gloves ready. A good spot to place my gloves is right here if the patient is unconscious, so they're right in front and ready to go. Otherwise, you can easily place them off to the side. I like to bend this down to make sure that the package stays open for me. And I am gonna go ahead and open this gown. This is one of those times that there are ways to do this with only one person. And if you're doing a procedure on your own, you might have to do it with one person. But you look to see which way your arms are gonna go through the gown, and you go ahead and unwrap the gown getting ready. I'm actually gonna ask for assistance here to essentially do the Velcro in the back. So we have someone who's gonna help with the Velcro in the back here. Okay, and then I'm gonna go ahead and begin to get my gloves on. So making sure that I don't breach the sterile area, putting the gloves on so that the cuff is all the way over the outside. And then I can either get my fingers a little bit better now, or I can do that later, making sure that I'm not touching anything on the outside with my fingers. Because remember that even though we're washing my hands, my fingers aren't sterile. So I'm gonna leave it like this for now. I've got these 3 fingers and a thumb. I'm gonna grab my gloves here. I'm gonna go ahead and put them on this way. Okay. So now I've got my gloves on, ready to go. And I've got this guy off. So now I said that I sterilized or at least used chlorhexidine once before. This is where I'm actually gonna do chlorhexidine for sterility purposes. So what I'm gonna really do is I'm gonna focus on doing for 30 seconds a mechanical scrub to the mannequin and making sure that, or to the patient, making sure that I really vigorously scrub that area that I'm actually gonna be inserting the needle where I previously had looked at the non-sterilely to make sure that I had a good target. Once I'm done, I'm gonna go ahead and expand my area here. And I like to actually do, in the real patient, a sterile area that's essentially the same as this insert. The reason I like to do it that size is because if I can't get the right side of the IJ here, I might need to end up getting some help and actually go into the subclavian. So what I'll do is I'll actually sterilize this whole area, make sure to focus right here where I'm actually gonna be performing all of my action, and then work my way out, making sure that I've sterilized this right subclavian also, just in case. So now that the patient has been sterilized with chlorhexidine for 30 seconds, I'm ready to go ahead and put the full body drape on. Now remember, I said this isn't a full body drape. So the full body drape will actually extend out in even further than what this is gonna be. You look at the sticker here, and you can see that it says head. What I like to do is I like to actually pull the sticker off, so I have my sticky area where I'm actually gonna do all my procedure work in there. I like to bend it in half, so that I can actually see where my target is gonna be, making sure that I remembered what side was head, which is this side up. So I bend it in half, and I can see that if I put my target right there, I'll be able to get my target dead center into my workspace. So I know that my target is kind of right there, so I'm gonna go ahead and go there. I'm going to push it down. And then the way that the vast majority of these drapes work is that they usually work by folding out like this and then folding up towards the head first. So I'm going to go ahead and pull up towards the head. And what I really want to do is, at this point, I want to, if I had this closer, like I said I would, I want to kind of drop this over the area here to ensure that I have a confluent sterile space that runs from the patient all the way to where my workspace is going to be. So I'm now going to ask my assistant to come over here and actually take this drape and pull it all the way down as far as it can go, only grabbing the bottom of it. So I'm going to hold it up here to make sure that we don't end up breaching sterile field and pulling it down. And I'm going to go ahead and hold it down while he extends it out and further and works its way down. And then I'm actually going to ask him to pull it as far as the drape will go. Remember that a full body drape will actually go all the way to the end of the bed, and so that will extend your sterile field all the way to the end of the bed. Now that I've got my sterile area, my sterile working space here, ready to go, the next thing that I'm ready for is actually taking the sterile probe. So I dropped this sterile probe cover onto the field. This is one of the trickier parts of the procedure. It's not hard, but this is where I see a lot of people make mistakes, and I might make a mistake as we talk about it, because no one is perfect, and that's one of the best parts about being in an educational world. So I have sterile ultrasound gel here. I'm going to identify the 2 rubber bands, which should be identifiable on somewhere in the package, and they're here, 2 little white rubber bands. And what the key is I want to identify how the probe is going to end up fitting into this bag. A lot of times you think that you just should put the probe in this way, but really this is the part that needs to be pulled away from the patient. So I'm actually going to stick my hand through here, kind of open up this space, and actually reach back through. This is the way that maybe this probe cover works, but I'm not 100% sure, and we'll find out in a second. So I'm reaching through here, and I'm going to ask my assistant, and be careful not to move the actual cart. Go ahead and turn the machine on and hand me the linear probe cover. Okay? So cool. And then I'm going to ask him to put on some ultrasound gel. And if there's no ultrasound gel available, I can go ahead and actually take a little bit of this sterile gel and put it off. I'm actually going to ask him to put some non-sterile gel on there. So let's say we had some non-sterile gel available, which I don't see any available for right now. So let's assume that we did, and this is actually non-sterile gel. He would apply some non-sterile gel there, and then I would ask him to hand me the probe, just like this. I'm going to take the probe head, and I'm going to extend this through. And I'm going to reach and push this as far as I can, and once it's extended, and I don't want to breach any field. Now that it's extended a little further, I want to extend it all the way, driving it actually on the patient, going this way on the patient's body, so that the length of the probe is actually on the patient. Because remember that your sterile field ends where your probe cover ends. So my sterile field now is essentially near the ankles, okay? And because of the positioning of the ultrasound machine, I can't necessarily get a better spot for it because that ultrasound machine's on camera, as you can see. But what I do is I take that first rubber band and I apply it to the top there. And I take the second rubber band and I run it down the length of this baggie, the sterile baggie, to make sure that we maintain sterility there. And we are ready to go. So we have our ultrasound probe, linear probe, ready to go. Now, some people will say that this is a good time to set up the kit, and they're not wrong. But what I am going to do is I'm actually going to take a step away from that and actually do this part where I anesthetize the patient at this point, because I have time to set up the kit while the patient is getting local anesthetics. Some people will set up the kit and then do the local anesthetics, and there's no right way or wrong way at this point. But what I am going to do is I'm going to go ahead and take the lidocaine here, which came in the kit. I'm going to be careful not to break it towards me. I'm going to break it away from me. And I'm thinking about how I'm going to be injecting the lidocaine into the patient. So the things that I'm looking for is I'm looking for a small gauge needle, oftentimes a 24 gauge needle to actually create the wheel. That's this one. So this is my lidocaine needle. I'm looking for a filter needle because I'm going to be absorbing glass. So there'll be a little bit of white cotton at the base of the needle, which is this one right here. So this is my filter needle that I want to suck up the lidocaine with. So I can tip it upside down. I want to break the plunger of any plungers I'm going to come across. I can go ahead and suck up. And this lidocaine syringe is only about 3 cc's. You don't need much more than that. You want to make sure that the patient is comfortable for sure. But 3 cc's is pretty good. I want to clear the air out of there, and we're ready to go. I'm going to take this filter needle, I'm going to put it away. And what I'm going to do with the lidocaine is I'm going to go back to the small gauge needle, and I'm going to create a wheel with this. Then the next thing I know I'm going to need to do is use a longer gauge needle to actually inject the deeper part of the anesthetics. And that deeper needle is oftentimes not available, and so you have to ask for a deeper needle, which we don't have. But you can use an 18 or a 20 gauge needle to anesthetize the deeper structures. But for this, what I'll do is I'll use the filter needle again to kind of show you what that looks like. So what I'm doing now is I'm going to go and create a wheel. And I like to create a wheel by just getting underneath the sub-Q tissue, picking it up a small bit, and then injecting a wheel of a generous wheel. So anywhere between like a centimeter to 2 centimeters worth of a wheel. And I inject it here, and then I kind of go 90 degrees. I inject it there. I go 90 degrees here. I inject it there, and I go 90 degrees. And I'll inject it there. Now once I've done that, I'll take that, and we're all done with the really small gauge 24 gauge needle. And I will go to the larger needle to do the deeper anesthetics. And the way that I'm doing the deeper anesthetics is I'm looking to anesthetize between the subcutaneous tissue and the superficial aspect of the IJ. So I'm going to go ahead and in the spot that I've already marked and know that I'm going to go into, I'm going to go ahead and use ultrasonography here. I'm going to find the artery and the vein, and we'll talk a little about that. I would actually apply some ultrasound gel at this point. But because I'm not going to be able to do this because of the mannequin's limitation, I'll just talk through it. I would actually go through, I'd find the needle tip, which we're seeing over there. So I'm actually a little off axis. I'm going to come out. The needle tip is right. So the needle tip is right here. You can kind of see it bouncing. And then I would actually anesthetize kind of the superficial structures here. But I'm going to go ahead and see there's the needle tip right there, coming, anesthetizing that, pulling this guy out. So now our anesthesia is ready to go. So now is the time that I said that some people say you should get the kit ready beforehand. I'll get the kit ready now. And the way that I like to get the kit ready is I like to go through step by step what I'm going to do first and get everything ready in that respect. So the first thing I'm looking for is I'm looking for the large gauge needle catheter complex. That's going to be the needle that the guide wire threads through. So that's this one here. And that's the first thing I'm going to grab. I can test the needle end with the guide wire. So the next thing I'm going to run is the guide wire. So I want to get the guide wire ready. And you can see that the guide wire has a special orientation to it where there's a hook to it. What I like to do is I like to actually get that hook facing downward so that when I actually do the procedure, that it's loaded in a way that it'll actually face downward. So what I mean by that is here it's facing up. So I'm actually going to run it like this so that when the hook goes in, it's actually facing downward. And what I'm going to do is I'm actually going to get this loaded. I'm making sure it slides through. I'm going to go ahead and get the end here ready to go like that. I'm going to test it against this needle and say, hey, does it run through? Okay. And it does. It's there. So now I'm going to pull it back, and that's the guide wire's been tested. It's ready to go. That's going to be the very next thing. After that, once the guide wire's in, what I know I'm going to need to do is I know I'm going to need to make a nick through the subcutaneous tissue and fat. So that's why I'm going to get this blade here as the next thing I'm going to grab. And the big key that I like to think about is if I visually cue myself to start grabbing things over and over and over, and I just get things ready in this order, I'll know what I need to grab next without having to think about it. So I've made the nick, and the reason I'm making the nick is so I can dilate appropriately. So the next thing I'm going to do is put the dilator in, kind of opening up that subcutaneous tissue in preparation for the catheter. So now this is a triple lumen catheter, and as you can see, there's a white, a yellow, and a blue. And in your kits, you'll have these caps. What I recommend doing, and most of the kits actually will have the caps attached, and those caps will have lure locks on the end of it. So I'm going to go ahead and actually attach the caps to the white and the blue at this point. And I'm going to leave the brown port off and uncapped. And the reason I leave the brown port off is because that's the port that the guide wire is going to have to come back through in order to actually feed back out. So now I'm going to go ahead and test this system to make sure that that the guide wire, that all the ports are good and that they're flushing okay. So you don't need a lot of saline. And what I would recommend is actually leaving the caps on because they've got lure locks. Because they're a little bit older, you need to use a needle. You won't come across these, so excuse me, I'm going to take the caps off. But I recommend leaving the caps on and actually doing this through the caps because they're lure locked. So I'm going to go ahead and take that, flush that. And because the cap would be on, I don't need to do the locking device. This is the locking device, but the cap itself serves as the locking device. So I'm actually going to just go ahead and pretend like I just pulled the syringe off, and the lure lock will lock it in place. Same with the white, making sure that the white is flushing. And here we are. We have a few drips there. And then the last one is the brown port. And the brown port is the port that you leave open because that's the one that you're going to have to feed the guide wire back through. But you can see that the fluid is coming out the end, and therefore we know that all three ports are functional, that we have tested the catheter. So the catheter is here. Then the next thing I'm going to need to do is apply the biopatch. So the biopatch is a patch that's antibiotic impregnated to make sure that you reduce the risk of CLABSIs. So I'm going to go ahead and put that next for my visual cue. And then because we're going to be going into the right IJ, we're only going to go about 16 centimeters in and not the full 20 centimeters of the syringe, which is there. And because we're only going to go to about right here, this anchor point at 20 centimeters is a little bit too far. So we're going to need to use a specially provided anchor device here. And these things are really kind of goofy. I'll show you what they look like when we actually get to that part. But these ones, it takes about once or twice of seeing them to really understand conceptually how they fit together. And hopefully by the end of this procedure, you'll understand how they fit together. The last part is that once I've got all that set, I'll actually take that extra chlorhexidine prep that I dropped on and put it right here. Because I want to do a cleanup kind of somewhere in this final stage to make sure that all the blood and all the fluid that's in that area that could serve as a nidus for infection, that I get as much of that off as I possibly can before I do the last part, which is this suture here. And if you want, you can take an extra suture and drop a suture and a suture driver on. Medicine physicians aren't that great at doing sutures anymore. I know that myself, that's one of my big sticking points. So I'll actually get a suture, like a legit suture and a suture driver. But you can just take whatever suture is there and just drop that there. So now that we've got all that stuff, we are ready to go. Assistant, would you mind turning on the ultrasound machine, please? So occasionally ultrasound machine will turn off. And so what you want to do is you want to make sure that it's on that particular mode. And that mode right there is vascular mode or superficial. That's called a vascular probe. And what we want to do is we want to take the rest of our ultrasound gel, which we have saved here, and now we want to make sure that we are liberally using it. Would you mind turning up the gain too? So occasionally you'll end up in a situation like this where the screen is a little bit dark. What you want to do is you want to ask your assistant to turn up the gain, or actually to hit auto gain. So most ultrasound machines will be calibrated to the point where the gain is the far bottom, turn it way up actually. Yeah, so it's almost like gray. So you really want to make sure like the perfect gain is a gain where the anechoic blood, the blood is jet black. And the rest of the tissue kind of looks a little bit like this. The rest of the tissue is a grayish hypoechoic / isoechoic appearance. Remember that blood is black, or fluid is black. Simple fluid is black, and more complex fluids can be hazy, or tissue can be hazy like that. We have two different sections that look black to me, so that's going to be probably an artery and a vein. The best thing to do is to use multiple checks to find out if you're actually looking at an artery or a vein. So some people will make sure that they examine for pulsativity. So here we're looking at both of them, and one is pulsing and the other isn't. So that tells me that on my screen, the artery is on the left and the vein is on the right. If I do a compressive test here, You can see that the artery compresses less than the vein. But what I like to do is I actually like to make sure that I'm not missing anything, and I'll actually ask the assistant to turn on color Doppler. So what color Doppler does is color Doppler generates a signal based on the direction in which blood is flowing, or which fluid is flowing. So if fluid is flowing towards the probe, it generates a red color. If fluid is flowing away, it generates a blue color. So what I like to do is I like to make sure that I'm oriented that the probe is oriented in some way, shape, or form in a direction. So you see I've changed the angle of the probe, the way that it interacts with that vessel there. And so away from the probe is that way. And towards the probe is this way. So cranial is towards the probe and caudal is away from the probe. So I'm going to go ahead and check for pulsativity here and check to see if there's any flow, and there isn't. That would be somewhat consistent with a vein. Even more consistent with a vein in this situation would be blood flowing away from this probe towards the heart, or a blue color. If I were to flip the probe around like this, it could generate a red color because now blood is flowing towards the probe. The same way like an EKG has some directionality, an ultrasound machine does too. So don't think red artery, blue vein. Think red towards, blue away. And the last thing I'll do is I'll actually check this other one here and see if there's a color signal in here. And what we should get is we're getting a color signal, and because of the limitation of the mannequin, it's not really red or blue because it's bouncing between kind of the plastic. So we've identified our artery here and our vein there. Danny, would you mind hitting 2D mode? Dr. Peter, sorry, would you mind hitting 2D mode? So now that I've identified my target, I want to characterize my target. I've already looked to see whether or not there's any risk when it comes to a clot. I've taken a look, and what I really want to do is I want to find a good spot where I'm not going to go through the front part of the vein, through the bottom part of the vein, and then end up in an artery because the artery is sitting behind. I want to be in a situation like this where the artery is on the left and the vein is on the right. Now, the key is that you want to identify the vein and the artery through the methods we just talked about. Don't remember right and left because 10% of anatomy will be deviated and flipped around. So really verify what you're looking at before you're actually going after it. So what I like to do is I like to kind of characterize the vein from start to finish, so from top to bottom, and kind of get a feel. So it looks like the vein on this model, on this human being, runs like this. So I know that this is the approach that I'm going to essentially want to be in. That's my line. The other thing I want to do is I want to make sure that I'm staying away from the lung, which is down here, because remember, pneumothorax is a big risk that we can create. Arterial cannulation is another risk. So when we're doing this, we're really characterizing our artery, our vein, our lung, our direction, our depth. So the other thing that I want to do is I want to verify that a spot that I've got, so this looks like a good spot to me, I want to conceptually understand where it's going to be in my head. I look at the bottom right of the screen, and I see that it's 2.6 centimeters to the end of the bottom of the probe visual screen. And so what I know is I know that at 2.6 centimeters, I'm back below the screen. I can see that big dot is 1 centimeter, so the target in the very center of that vein is 1.5 centimeters deep. So now that I've characterized it in all these ways, I know that I'm ready to get started. So the thing is that this is kind of a little bit of trigonometry. You can think about it a couple different ways. Is if you're approaching it at a 45-degree angle, you're going to go, if you're going to be 1.5 centimeters back down, then you want to start 1.5 centimeters back. Because remember that the adjacent and the opposite to the angle of 45 degrees is exactly the same. The other way to think about it is, hey, we're going to be using a needle. We're going to be watching it the entire time. So you can go at a little bit shallower an angle if it's closer. If it's deeper, you can go a little bit at a little sharper of an angle. But realistically, we're going to be watching the needle the entire time. So what I'm ready to do is I'm ready to get started. So I have the very first thing I'm going to grab is that needle. And remember, I set it up first. And here, the catheter. So what I'm going to do is I'm going to break that plunger. Like I said, anytime you're about to use a plunger, always make sure you break it. Bevel up. Make sure that the bevel is up. And I'm going to go ahead and create a small suction. So I'm getting ready to create a suction here. And now here's a big key. So I know that the vein kind of runs this way. And I've got that green dot right there in the center. That green dot matches up with an arrow or a triangle on the probe. So the reason that this is so valuable is that what I can do is I can make congruent what I know is underneath the skin with what's outside the skin, that triangle. And I want to make sure that I'm essentially using the markers that exist on the probe itself to help me once I get into the body. So the first thing I'm going to do is I'm actually going to take the probe and I'm going to have it so I can see it, okay? And then I'm actually going to take the needle. I'm going to put the needle in. And I'm going to look for that thing at the top right there. That's called a ring down artifact, okay? And I'm maintaining a vacuum here. And what I'm looking for is I'm looking to make sure that I know where that tip of the needle is. To know where the tip of the needle is, I'm actually going to advance the probe a small bit forward until that ring down artifact goes away. So the ring down is kind of right there. You see it at the top, right where the green dots are. And if I move it forward and I'm shaking the probe, it's gone. And I move it just a small bit forward. And now I advance the needle a bit, and there's the ring down again. And now I advance the needle, I advance the probe a little bit, and I advance the needle a little bit. And I'm getting closer. You see I'm about 1 centimeter right now. You see that silver area right there. And then I advance it forward a small bit. And I go a small bit forward. I'm tenting now. And when this happens in real life, when you're tenting, you can just bounce it a small bit and you'll get in. But remember, I'm maintaining a vacuum. So the fact that I'm maintaining a vacuum I know by feel that I'm not in the vein. I can confirm by ultrasound that that's the case. Realistically, what I'm really doing is I'm looking at ultrasound and I'm verifying by feel. And if I just go forward just a small bit more, I know I'll cannulate based on what I'm seeing on the ultrasound. And here you go. We have our flash. So now that we've got our flash there, we want to make sure that we've got a consistent flow. We're going to drop the needle tip. We're going to advance it just a tiny bit more and actually drop the needle head a small bit. Now we're going to make sure that we're all anchored here. Our non-dominant hand is anchored. And we're going to go ahead and take this and twist this off. So just the needle is in. Remember that we said that it's going to bend downward. So I want to put this guy in like this. And we want to go anywhere between 10 and 15 or so. And if you hit resistance, you should stop. But right now we're at 15. I've got 3 dots. I'm going to go ahead and grab, remember that the only thing you can't do is let go of the wire now, okay? So, and I'm holding on to the needle and the wire. I'm pulling this out. And what I want to do is I want to make sure that I've got good control of the wire at all times. I'm going to bend the wire back. And this is one of the tricks that you can do to make sure that you're working in the smallest space as you possibly can. And now I know that I can twist this needle out and I should be able to keep it in the vein. Now that I've twisted it out, I've got access to the wire on the proximal end here. I'm going to go ahead and switch my hand, grab that, never let go of the wire, and pull this off. Now that I've got a wire in a body, you're not in trouble if you've managed to get into the artery. You want to make sure at this very moment that you're not in the artery though. Because the moment that you dilate and the moment that you cut and the moment that you cannulate in an artery, things can get really messy really fast. So what we want to do is we want to make sure that this wire, which is in this body, is in the proper place that we want it to be. So we're actually going to take our ultrasound here. We're going to track the wire, and we actually can see that ring down in this vessel here. The best thing to do is actually take this vessel, turn it on long axis. So that means we're actually looking at it in the longest possible axis, meaning a longitudinal axis. And we're actually going to see if we can find the needle entering the vein. And what we have here is we have the needle entering, going through the subcutaneous. And right there at that green dot, right there, you can see at about 1 centimeter, that's where the interface between the wire and the vessel cannulation is occurring. And you can see that it's bending down and following the length of the vessel. And if we follow it down, you can see it continues further and further and further in that vein. Now, the other thing to do is to still identify the artery at this point and make sure that there's no chance that we cannulated that. You can ask your assistant, which I'm not going to do right now, to turn on 2D color. And that's something that you can do to make sure that you're in the right spot. The same way that we checked before, you can check again. But we're not going to do that. That's unnecessary. If you're, so now, because I set it up the way that I set it up, I can just look here and say, what's the next thing I need? And just looking here, I grabbed my wire, which was the next thing I needed. I know that the blade is coming up next, that the nick is coming up next. Now, I'm going to show you how to do the nick in the way that I recommend it. Some people might have some other different approaches, but this is the way that I want, this is the way that I learned it, and this is the way that I'm going to teach it, because safety is one of the most important things here. because of the mannequin being the way the mannequin is, I can't demonstrate it on the mannequin, so I'm going to let go of the wire, okay? Never let go of the wire, but for these purposes, for demonstration purposes, I am going to let go of the wire to show you over here what I'm talking about when I say there's a specific way that I want you to cannulate to do the blade. So this is an 11 blade, and there's, like any blade, the sharp end and the dull end, okay? Now, this is one of the higher risk moments of this procedure, because if you come in with the sharp end and cut against the wire, you can actually end up cutting the wire off at the proximal end of to the patient, and you can introduce a wire embolism, and that's one of the major risks that can happen here, and that's one of the more common ways that it happens. So beyond not letting go of the wire, never cut the wire with the blade facing down. Rather, what you want to do is you want to face the blade upward, so that the blade is actually pointing towards the sky. Now, we pretend that this right here is our wire in the body, similar to that right there. I'm going to show you how I recommend that you do the blade nick. So we're going to actually take the blade face up, and there's a small little groove there. You take that groove, and you essentially follow the dull groove with the sharp side up, and you actually follow it into the tissue. So this way I know that my blade is on the opposite side of my wire and that the risk of cutting that wire is minimal. I'm opening up the subcutaneous tissue so that I can effectively dilate and then run the catheter in. So that's how I want you to do the blade. So now we're going to go back to the procedure, pretending that I never let go of the wire. So we're back here. So now the next thing we're going to do is we're actually going to dilate. Because what we have to do is we have to open up the soft tissue enough to be able to fit the catheter in. Because of the limitation of the mannequin, I can't dilate this all the way, but I will show you how to do it. So remember that we want to work in a small space. So I'm actually going to once again fold this wire back over so that I can access it here. I'm going to go ahead and feed this through. And I'm not letting it go. I'm feeding the wire back. And once the wire pops out this, I know I can grab this side. This is a safe side for me to grab. Now I'm going to go ahead and, continuing to hold the wire here, I'm going to go ahead and spin this into the patient. And what I effectively do is I spin it, and you don't need to get it so far in. You just have to get to where the fattest part of the dilator exists. You don't need to drive the whole thing in. You're not putting in a pulmonary catheter wedge pressure Swan-Ganz. You're not doing that today. So skip that part. But dilate, 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 open it up, pull it back. In the same way that we got the needle out, make sure that you're controlling the wire close here. Grab that, pull that out. Now we want to fold this back over, because the next thing, as we're looking, is, guess what? It's go time, our catheter. And remember that the way that we have our catheter set up is that the white and the blue ports are filled with fluid and they're capped. The brown port is uncapped, and now is a good time to check that. You won't come across any other, you won't come across these types of caps or these types of catheters, but it's good to kind of think about that. So what I'm going to do is I'm going to kind of keep all this stuff close because I want to work in as small a space as I can. And I'm going to go and begin feeding this catheter through, making sure that I'm walking the wire through. So now I'm going to get to kind of a funny little spot here, which is I've run out of space on the wire. I'm still holding it, but I've run out of space on the wire, and I can't grab that wire on the other side. So what I'm going to do is I'm actually going to pull the wire out just a small bit, just a smidge. Let this guy feed forward, and now that I've got access to the wire on this side, I can grab it on this side. Now that I'm holding it on this side, I can let go of on this side, switch, and now feed the rest of the catheter in using my dominant hand. And there can be a little bit of twisting that you do here to get this guy in and through. And remember, I'm not letting go of this at all. Not letting go of it. And remember, we said we're going to about 16 centimeters. So this is 20, walking way back, 19, 18, 17, and actually I went in just a smidge for 16 right there. Now that I've got the wire and I haven't let go of it, I've got the catheter in place. I can go ahead and pull this wire out, place this off to the side, and now we've effectively cannulated. We placed our first central line here. So congratulations to us. What we want to do, though, is it's in, and we want to test it. This is where you'd actually use the saline that got dropped on your field, and it does not look like I have all that much saline left here. So what I'll do is I'm going to use this blue fluid, which is actually the fluid that came out of the mannequin. Remember that you want to make sure there's no air introduced. You want to have this kind of face up. You actually want to pull it back first to get the air out. We got the air out, and now you can insert some fluid there. This is a good time to grab this, and what I'm going to do is I'm going to lock this here just so that there's no, you never want these lumens to be open to the air. And so it's a good time to put the cap on at this point. So once that's in, you can cap the brown, and then you can retest it through the cap. And because these caps, because we know that the brown flushed, I'm confident that the white and the blue would flush, but in real life, you'd want to flush those also and make sure that those are working. Doing the exact same thing where you're pulling it out first, driving any air out, making sure that you got it up and down so that you don't introduce any air into the system, and then flushing it that way. So now we've got our catheter in, got our caps ready to go. This is where I like to grab the extra chlorhexidine, and I actually will wipe with the chlorhexidine. I'll break it open the same way, and I'll wipe any of the excess blood, making sure that I'm leaving as clean a field as I possibly can to minimize any kind of risks that exist there. I have the BioPatch, and the BioPatch is one of these. It's got a slit in it, and remember I said blue side up, blue towards the sky. And I take the BioPatch and I put it right next to the patient's skin. In fact, I put it on the skin. The last piece to this part of it is I take the anchoring device. And the anchoring device, like we said, is a little bit goofy, and I told you I'd show you how it works, and this is where I'm going to show you now. So this is oftentimes a blue and a white part, okay? Occasionally this can be a little bit different colors, but it's always the same kind of design where there's a little rubber gasket that goes around the whole thing, and then the white solid anchor. So this is flexible, this is hard. You take the flexible anchor and you essentially snap it on pretty close to where it's coming out, because you want to minimize the amount of space between the actual body and where you're anchoring it down to the body. Now that you've got the flexible piece here, you want to make sure that you're anchoring something solid. So the blue is on, the flexible piece is on. You take the white and you just snap it over top. And what you've done is you've created a really durable suture locking area. Now the last thing that you're going to do is you're going to take the suture, and here you're going to open up the suture. You're going to suture here, and you're going to suture there. You're going to place a cover derm here, and you can use, occasionally there'll be an anchoring thing for the lines. You can ask the nurses. We have that over there. And that's effectively the entire procedure from beginning to end. Now that we've got the procedure done, we've got this dressed, we are able to break sterile field, and we are able to celebrate. Thank you so much. I really appreciate taking the time watching this. If there's any questions, please feel free to ask. Really, any proceduralist, any critical care physician, anyone that is educated in this procedure. Like I said, occasionally there's a little bit of nuance in the approach of doing it. This is only one approach. It's not the best approach. It is an approach. And so if you've been taught a little bit differently, as long as you've got the main skills, you haven't breached sterile field, you checked the vein, and that you've really used the chlorhexidine appropriately, those are the big keys. Thank you so much. Have a good day.